Okay, at the same time, it's also a topic that will give you a lot of scoring, because invariably, somewhere or the other, this question will come about community acquired pneumonia, and there are small key points in community acquired pneumonia that you should know. Okay, so first of all, you will get very, which are the sources from where you have to read it. First, if you ask which are the sources from where you have to read community acquired pneumonia for the ICU, there are two important guidelines. One is the IDSA guidelines, the other is the ESCAMED guidelines. Okay, ESCAMED guidelines, ERS guidelines, that is. ESCAMED, ERS and ALA have come up with a guideline which come in 2022. Okay, and you have the IDSA guidelines which are there in 2020. So there are two guidelines that you have to refer to when you are actually reading community acquired pneumonia, severe community acquired pneumonia. There are also Indian guidelines, but unfortunately the Indian guidelines are both severe as well as non-severe community acquired pneumonia, so it might throw you off. Okay, but you have to read severe community acquired pneumonia guidelines that come from IDSA and from the ESCAMID, ESCMID. Okay, so this is something you have to read from. Okay, so this is the first thing that I must tell you. To supplement this from a guide or something like that, the easiest book to read is OAS in this case. Okay, OAS is the easiest guideline from where you can read this community acquired pneumonia. Okay, and the rest obviously you must listen to what I'm saying, because this is some questions that are going to come in. Okay, which will not be written anywhere, per se, you'll have to understand these questions. Alright. So, when you say community acquired pneumonia, it's not only that pneumonia that comes from the community, it's also the pneumonia that comes into the hospital within 48 hours of the hospital admission. Within 48 hours, not after 48 hours. So, if a patient comes from outside, you don't know what it was. Next day, you found a patch in the X-ray and you found fever leukocytosis. This will go in favor of community acquired pneumonia. So, by defining, you also have to put the timeline in place, saying that it is less than 48 hours of admission. Okay, so severe community acquired pneumonia is a pneumonia that you diagnose which occurs within 48 hours of admission or comes in from the community with the diagnosis of pneumonia. Right, so how do you diagnose pneumonia? If somebody asks you how to diagnose pneumonia, there are three important features of pneumonia. One is an imaging finding. One is an imaging finding that actually shows a kind of a homogeneous opacity in the zones. The second would be an inflammatory finding. When you say inflammatory finding, would be leukocytosis, fever, all these things would come in, and symptoms and signs which will say auscultation showing crackles and rills. This is exactly what you mentioned in your first slide. Okay, so you should divide them into three parts. Okay, laboratory investigations, put up the signs and symptoms, and the imaging modality. Okay, so you put these three things together to actually call it as community acquired pneumonia, and to call it severe, what do you do? To call it severe, what do you do? To call it severe, what do you do? So because that's where your basically entire thinking is what do we do with severe. Because we are talking of those patients who come to the ICU. So a patient comes into the casualty, and now you have to decide your call from the casualty that sir, एक patient आए आके देख लो, क्या करना है patient का? That's how the call will come in. So what do? I want the disposition of the place where the patient should go. Should the patient go to the ward? Should the patient go home? Or should the patient come to the ICU? So to find that, the easiest criteria that you can use. No, CRP 65 is specifically for hospital, not for ICU. So you must understand, the CRP 65 is specifically for hospitalization. So if you have a patient who is confused, uremic, respiratory rate more than 29, 25 and blood pressure less than 90, out of two of these three, if there are, so you don't say the uremia, that's why you don't going to look at uremia. Because if you think of uremia, more than 20, whatever the milligram per DL uremia look at, you're going to wait. Understanding? So if a patient comes to the casualty, you're going to send a BUN to find the uremia, right? That's why uremia is out now. We're using CRP 65. Okay, so when in CRP 65, when there is 2 out of 3 that is coming in, that patient requires to be at least hospitalized. Clear on this? CRP 65? CRP 65. The question that comes is, okay, I am going to hospitalize. Am I going to send her to the ward? Am I going to send her to the ICU? For that, I need to look at the ATS criteria. The ATS criteria that she said, 1 major and 3 minor. So out of those, so one major, the major is very obvious. Mechanical ventilation, septic shock can't remain in the ward. That is going to come to the ICU. So any of those that comes in, that patient will come to the ICU. And when you say minor, out of the 9 criteria that you have, 3 should be there. 3 plus should be there actually. When you say 3 plus, it's very simple. Hypothermia, PF ratios, multilobar opacities. It's all very, very simple. RR more than 29. These are very simple. WBC count being more than 14,000, less than 4,000. There's all very clear criteria that are there in that. Okay, which actually tells you that all 3 plus of these criteria will actually tell you this patient needs to be in the ICU. So, in short, if you are seeing a patient in the casualty, CRP 65 will tell you whether the patient goes home and remains in the hospital, whereas ATS will tell you whether the patient requires to be in the ICU or in the wards. Clear on this? The pneumonia severity score is very difficult to calculate. Right? It's based on a large number of things that come into the place and you can't really remember it. But the ATS is something you can easily remember. ATS, that's why you need to know the ATS criteria. You understand? The ATS criteria will equal 2 out of the first 2, 1 out of the first 2, that is mechanically ventilation or septic shock with requiring vasopressors, and 3 out of the last 9. Out of the last 9, when you say septic shock, you remember aggressive fluid resuscitation if you require, that's 1. Okay, temperature less than 36 is another one. Leukocytosis is another one. PF ratio is another one. Multilobar obesity is another one. RR more than 30. So it's very simple. If you just remember vital parameters, it's as simple as that. It's not difficult at all. Are you understanding? So with that, now you know that this patient is coming into the intensive care unit, right? Now this patient is coming to the intensive care unit, and now you have to decide what are the investigations I need to send and why. Isn't it? So whenever you're talking about community acquired pneumonia, you are not talking about immunocompromised patient first of all. Whenever you are looking at guidelines, these guidelines are specifically for non-immunocompromised individuals. Immunocompromised individuals are completely different. Okay, so you can't club both of them together. When you're talking about community acquired pneumonia, severe community acquired pneumonia, talking about individuals that are not immunocompromised, normal individuals. Because why? Because there is a separate guideline for those patients who are immunocompromised. You understand? So tomorrow if I say this patient has chemotherapy that has been induced and patient has come with RR of 50 and the patient is uremic and patient's age is 70, that I cannot use the curve 65 and all these things on that. I can't use ATS and the immunocompromised is different. Are you understanding? Because why is it different? Why do you think it is different? Why do you think it is different?
Their response to change effect.
Yeah, absolutely. So they may not show any response. So you can't use the usual criteria for an immunocompromised patient. They don't show any response. They may show the X-ray to be normal. They may show no fever. They may show no tachycardia. Plus, you cannot send the usual investigation they are going to send for them because they require a different set of investigations. We'll come to that when we discuss immunocompromised patient. You understand? So this criteria that we are talking about is for what? For normal patients which are not immunocompromised. All these guidelines. Remember this, okay? Because this is a catch question that comes in the exam. Okay. Also, you must understand on a front clinically when you are managing a patient, you must understand that there is difference here. This patient is not the regular patient. There has to be a difference between both of these. We must understand this, okay? So whenever we are taking talk here in this room, we are not taking a talk for exam. Exam, yes, but we are taking a talk for life. To how to manage these patients. Remember this. So you don't just consider this for an exam. So I am just teaching you how you want to become better doctors. Okay, it's not just getting through an exam. You understanding? So that way you should start thinking: is this patient immunocompromised? If he is immunocompromised, then I actually need to think in a different way. Okay, now this patient comes into you to the intensive care unit, and you have diagnosed this patient to have. You're in the diagnosis, and you have a suspicion that this patient has got severe community acquired pneumonia because this patient has come into the intensive care unit. So the investigations that you'd like to send at the baseline would be actually initially starting with a blood culture. This blood culture that you're sending has to be 2 sets. They have to be 2 sets. And classically we say, if you're going to send 2 sets of blood culture, it is better to send it 30 minutes separately. Don't send it 4 blood right now. You understand? When you say 2 sets, 1 set is 1 aerobic, 1 anaerobic. 1 set. When you say 2 sets means 4 bottles. 4 bottles. So when I'm sending 4 bottles, don't just say take 4 bottles and send it immediately. Classically what you do, you take it after, take 1, wait for 30 minutes, take the second. Are you understanding? And why is that so? Because there is not a 100% probability that you will grow something from that. Okay, that's why you need to time it in such a way that you have some time gap between both. You may be seeding at a different time, you may be catching a bacteria at a different time. That's why 30-minute separation is what we require in most of these cases of blood cultures. Clear on this? So this will work. Blood cultures are only for severe community acquired pneumonia. They are not for otherwise. So you're not going to send a patient to go into the ward for a blood culture. Are you understanding? In the ward, the blood culture is not going to reveal anything. You're going to do this for patients who are coming into the intensive care unit. These are those patients who require blood cultures. Clear? Then which is the other set I want to do? The other test I want to do in these cases at this moment is actually a sputum, gram stain and culture. Very important. Very important to get a sputum, gram stain and culture. And why is that so important? Because our basic issue is at this moment we don't know the bacteria. Our basic issue is we don't know what bacteria it is, and because of that, what are we doing? We are giving antibiotics. And what are we giving? We are giving broad spectrum. What if this is not required? Where is this broad spectrum going? It is going into the groundwater. It is going to pollute the atmosphere. It is going to cause antimicrobial resistance. Not only that, we may end up giving the wrong bacteria, the wrong antibiotic. If you're going to give the wrong antibiotic, first of all, you're given a wrong antibiotic, it has gone into the groundwater and caused antimicrobial resistance. Second, you're given an antibiotic which was not supposed to be given to this particular patient, caused antibiotic resistance and selection pressure inside your unit. Inside, you see, first of all, you have created a problem for the community. The second thing what you've done, you have given an antibiotic, and now in your ICU there are certain bugs. I know the flora of my ICU. Okay, now I have given an antibiotic that was not supposed to be given for that particular. It's not acting on that bug. So what it does, it causes a selection pressure of resistance. Selection pressure बोलते हैं उसे, जहाँ पर you are not really treating it and that is getting stronger and stronger. So there is a selection pressure of that resistance mechanism in that particular patient. So that selection pressure will move out. You understand? Second problem, you have created a problem for the community. You have created a problem. When I say community, it means create a problem for yourself. The second thing, you have created a problem inside the intensive care unit because you have caused a selection pressure. The third thing, most probably this patient may not survive or may do worse because length-of-stay will increase because you have given the wrong antibiotic. Are you understanding? You give the wrong antibiotic. And fourth, the patient's length of stay increases. So what increases? The cost increases. So you have had all four problems. So our basic problem that we have is what is the organism? Our basic problem is what is the organism? Unless we get what is the organism, it is really wrong to go ahead and do anything. Are you understanding? So what is the organism becomes very important, and that is why we require an excellent sample from the respiratory tract. It solves all the problem. An excellent sample from the respiratory tract means a very good sputum sample. And when you say very good sputum sample, what does that mean?
More than 25
polymorphonuclear cells and less than 10 squamous
Epithelial cells. So more than 25 and less than 10 squamous epithelial cells. Very, very important to see that. Or more often, apart from that, one bacteria. Okay. If you have polybacteria, some 4 or 5 bacteria coming in, maybe it's a sputum sample, maybe it's something that's coming in from the throat. It's not something that's coming in from the respiratory tract. And that is why elucidating that sample becomes very, very important. And that is the reason that if you manage to intubate your patient, the first thing you should do is to send an excellent sample that comes from the endotracheal tube. That is the best sample. Okay, where sometimes it does happen that you don't get anything. That's fine. You may not get anything. That's okay. You put 20 cc of normal saline inside. Put maybe 40 cc, maybe 50 cc. There is no harm. Put 50 cc inside. Okay, put 50 cc, put 100 cc also no problem. Because it's water after all. It will get absorbed. There is no problem. It's not going to aspirate and cause the patient to drown. That's not going to happen. You put 50 cc inside, wait for some time, take out that 50 cc and send it for culture sensitivity. Very, very essential. You've understood why. You've understood why we need that sample. Is it very clear? Why we need the sample? Is it very clear? We need that sample because without that we are really in the wrong track. Without that we are really in the wrong track. You're understanding? So sputum, why is that? And in that sample, what is very important for you to figure out? What is the gram stain? Gram stain is something that will come very quickly. Okay, they see on a slide, they see gram positive, they see gram negative, you start thinking. Do I need to add something? Because what I've done in her community acquired pneumonia severe is that she's added a beta lactam, but she's not added an MRSA cover. She's decided based on should I or shouldn't I. Isn't it? So I may be able to take off something from there. Are you understanding? Clear? Now this will completely change when you're coming to immunocompromise. So we'll side by side do immunocompromise. First of all, what is an immunocompromised individual? Oh, let's not go to that. We'll go completely separate to that. Okay. So sputum, clear on the sputum gram stain and culture? Clear? Clear on sputum gram stain and culture? Any doubts still on sputum gram stain and culture? What is the problem with sputum gram stain culture? The problem A is that A you may not get or something. You may not get something. So what do you do to get things out? You can use isotonic nebulization, you can use hypertonic nebulization, you can use aggressive physiotherapy, and you can give positional techniques to get that out. So, but you have to put all your effort to get that out. Okay, you have to put all your effort to get that out. Very, very important. Okay. Now, what is another problem with sputum gram stain culture? The other problem is this is going to take an approximate 48 to 72 hours before it actually gives you. That means, say for example, you have a patient with Acinetobacter pneumonia. The patient has severe communicable pneumonia, isn't it? Huh? What if this patient has got drug-resistant pathogens, or if he has got Acinetobacter, or if he's got Pseudomonas? What have you done? You have actually given the wrong antibiotic. You have increased length of stay. You have caused selection pressure, and you have caused antimicrobial resistance. Are you understanding? So, when I am looking at 3 days sputum gram stain culture, I am really worried. Right? Because for 3 days time, I am in dark. I think it's working, it may not be working. I think I have given the right antibiotic, it may not be the right antibiotic. And that is why I need different techniques to figure out what I should do. And the technique that we have used and we are getting, and we are fortunate to be in that era, is that we have PCR technology. That's where we are fortunate. We are fortunate because we are now in the era where we have PCR based technology. What is PCR based technology? PCR based technology is a technology that gives you answers within 6 hours in the right time. If I have my automated platform here, PCR technology right in my hospital, from the time of collection to the time of report, it is only 6 hours. In fact, lesser than that. Okay, in fact, lesser than. You understand? So, what does this do? It actually cuts your antibiotic days by 2 and 2.4. It actually cuts your culture positivity by 2.5 days. It's removing your culture positivity by 2.5 days. Are you understanding? Before 2.5 days you've got it. Now why is this so important and why is this supposed to be done? Because when are you supposed to do this? You supposed to do it in all patients? I will do it in those patients in which I have a feeling that I'm not going to use my usual antibiotics. That is the recommendation. The recommendation is, I have a feeling I need to use Cefepime-Tazobactam. I have a feeling I should be using Meropen. I have a feeling I'm using Imipenem. I'm not using Ceftriaxone. I'm using something higher. Okay, if I start thinking like that, then I'm going to use something like that, then I send a multiplex PCR. This is the ideal world. The ideal world, if I had all the money in the world, if I had no problem with funds, if I had no problem with anything, ideally, any patient that comes in severe communicable pneumonia here, and I think of drug-resistant pathogens or Pseudomonas or Acinetobacter, I want to do multiplex PCR because I know that if I don't treat Acinetobacter and Pseudomonas early, mortality is very high. If I don't treat Acinetobacter and Pseudomonas early, mortality is very high. You understanding? So the entire point is, with my multiplex PCR, will I be able to get Acinetobacter and Pseudomonas? If I get it, I will change my antibiotic. I have already de-escalated or escalated. You understanding? That is why the entire thinking is multiplex PCR. But that's not all that simple. So you might think a lot of other things that will come to your mind the moment you think of multiplex PCR. You would start thinking, okay, if I have it negative, what do I do? Multiplex PCR can be negative. You might get negative. What do I do? Do I de-escalate my antibiotics? I can't. So multiplex PCR cannot allow you to de-escalate your antibiotics. You might think this way, multiplex PCR is not showing me any atypical bacteria. Can I just remove my atypical cover? You still can't do that. Multiplex PCR cannot still allow you to do that because there are no randomized control trials that has helped us to do that. You understand? Now why are we talking about multiplex? Multiplex, what is the meaning of multiplex? When you say multiplex PCR, it means you are looking at a group of bacteria, viruses and fungi. But when you say multiplex PCR, you are looking at a group. It's not like nasopharyngeal PCR for RT-PCR COVID. See, that RT-PCR was one, just SARS-CoV-2. RT-PCR was just one. What was it? SARS-CoV-2. Right? It was just one thing. But when you say multiplex PCR, you are looking at a whole lot of core respiratory pathogens. You are looking at a whole lot of core respiratory pathogens, and it's called a syndromic multiplex PCR. Why is it called as nowadays syndromic? Because there are various multiplex PCR based on the syndrome that you are treating. So for example, if you have a GI problem, there is GI tract multiplex PCR. If there is a CNS problem, we have CSF multiplex PCR, which we call as CSF BioFire. You understand? Syndromic multiplex PCR. So they have converted into syndromic multiplex PCRs. Are you understanding? So we are doing a respiratory multiplex PCR. Are you understanding? Clear on this? When you say core respiratory pathogens, which are the core respiratory pathogens you described?
Streptococcus pneumoniae, H. influenzae,
And
then viruses.
Streptococcus pneumoniae,
H. influenza.
H. influenza, You are in gram positive. Streptococcus, you must know it's like this. Gram positive, Streptococcus pneumonia, Staph aureus, H influenza. That's gram negative. Then Streptococcus pyogenes. Streptococcus pyogenes, Staph aureus, and Streptococcus pneumonia. Why am I talking about this like this? Why am I telling like this? Unfortunately, Streptococcus pneumonia doesn't grow quickly. Unfortunately, gram stain mein, since it is the commonest, but it doesn't grow quickly. Sir will call you. I can give this urgent karke. So Streptococcus pneumonia will not grow immediately. You're understanding? Are you understanding what I'm saying? Huh? We would think Streptococcus pneumonia is the commonest. So I must see Streptococcus pneumonia fast, but I'm not able to see. It's not able to see because it doesn't grow that quickly. That is why multiplex PCR makes a difference. Are you understanding? Multiplex PCR will immediately tell you Streptococcus pneumonia. Whereas in gram stain culture to grow, it was a difficult day. Compared to Staph aureus. Staph aureus, tuck karke you will grow. You will get Staph aureus immediately. But there have been monoplex PCRs for Staph aureus abroad and in India. There is specific PCR for Staph aureus. Are you understanding? Why is that specific PCR there for Staph aureus? Because whether to give MRSA cover is still a question for us. We still don't know whether to give MRSA cover. Are you understanding? The reason why we gave, if you remember last time lecture I said, in the hospital it is okay if you have more than 10% MRSA, you would give MRSA cover. But your patients coming from community. Okay, which patients of the community will require MRSA cover? If you remember last time I did talk about nasal PCR, short score, 3-4 things together and I tell you use MRSA. Can't do this in all patients. So what the world does is do a multiplex PCR, not a multiplex PCR, do a PCR for MRSA. You do a PCR for MRSA. If it is negative, don't give the MRSA. I mean, if it is positive, give the MRSA cover. If it's negative, you still can't rule it out. Clear? Now in this it's important when you're doing it, when anybody talks about MRSA PCR, they always talk about MRSA plus MEC gene, MEC1 gene, MEC-A gene. There is something called MEC-A gene. So whenever you read a biofire, you will see MEC-A gene written on it. Okay, MEC-A gene. MEC-A gene is a gene that is responsible for MRSA. It is also responsible for cognizant negative Staphylococcus aureus. So you become a Staphylococcus aureus. You want to know whether it's MRSA or whether it is cognizant negative Staphylococcus aureus. By just doing MEC-A gene, you can't do it. You have to have MEC-A gene plus MRSA. You can't have MEC-A gene on its own. You might think, I might just do the gene. No, I'll just do MEC-A gene. I'll explain to you again. MEC-A gene is common to MRSA as well as cognizant negative Staphylococcus aureus. It is common to both of them. Okay. You might think, why to do two different things? I will just do MEC-A gene. If I do MEC-A gene, I will get the answer. But no, I want to find MRSA. So I need to do PCR with MEC-A gene plus MRSA. You understand? I need to do both of them together to actually figure out MRSA. Clear? Clear on this till now? Multiplex PCR. The multiplex PCR in present scenario, we have two types of multiplex PCRs. You have nasopharyngeal and you have lower respiratory tract sampling. You can't send nasal swab and write LRTI. You can't. You understand what I'm saying? So when you're looking at syndromic PCR, there would be upper respiratory tract and there will be lower respiratory tract. Both of them have different bacteria. Next time when you're seeing biofire report, see, or you are in the net, you can see biofire will have upper respiratory tract and lower respiratory tract. The bacteria are slightly different from both the sides. This will require nasopharyngeal sampling, not sputum. This will require endotracheal aspirate or deep sputum or bronchial lavage. You can't do nasopharyngeal swab and send LRTI. Because you might say, are इसमें streptococcus दिख रहा है, चलो ये भेजते हैं. Are you understanding what I'm saying? The sampling determines what you're sending. समझा कि नहीं समझा?
So, but then for LRTI, if we are not getting sputum, then what we'll have to do bronchial lavage.
You understand, na? Because upper respiratory tract sample will have different bacteria, lower respiratory sample will have different bacteria. But the upper respiratory tract has been done only for nasopharyngeal swabbing. Because you might say, ये इसमें streptococcus नहीं है, इसमें streptococcus है, चलो ये भेजो. लेकिन अगर ये भेजना है तो nasopharyngeal swab नहीं भेज सकते हैं. समझ में आ रहा है? You are understanding or not? Pen किधर है? तेरे रूम में रहेगा देखो इधर. You are understanding what I'm saying? समझ में आ रहा है? हाँ, क्योंकि ऐसा हो जाएगा तुम लोग जब देखोगे ना सैम्पलिंग देखोगे तुमको देखेगा कि अपर रेस्पिरेटरी ट्रैक में तुम ये सब बैक्टीरिया है, लोअर रेस्पिरेटरी ट्रैक में ये सब बैक्टीरिया है. अपर रेस्पिरेटरी ट्रैक सैंपल में फनीली स्ट्रेप्टोकोकस निमोनिया नहीं है. हाँ, तो तुमको लगेगा ये तो कॉमन स्ट्रेप्टोकोकस निमोनिया है, मेरे को तो निमोनिया डायग्नोज करना है, तो नेसोफेरिंजियल स्वाब करो, लेकिन एलआरटीआई भेजो, वैसा नहीं कर सकते. समझ में आ रहा है? हाँ, एलआरटीआई में स्ट्रेप्टोकोकस निमोनिया आएगा, उनको ब्लॉकर दवाई करना पड़ेगा देखो. So you understanding? हाँ, clear on this? Multiplex PCR, you understood multiplex PCR, you understood this? Okay. Now, which patients of these will actually require PCR for H influenza, which is influenza virus? You also have, we just now said, in the core respiratory pathogens, in gram positive, you said Streptococcus pneumonia, Staphylococcus aureus, and Streptococcus pyogenes. When you said core respiratory pathogens in the viral domain, you said there is respiratory syncytial virus, there is influenza virus, and there is the presence of COVID virus. Isn't it? These are the three viruses that we are looking at, which might be core respiratory pathogens over here. Also, influenza virus, isn't it? Influenza virus. Right? In the gram-negative spectrum, you have the other list, which we talk H influenza and all the rest of the things, and plus Klebsiella, Pseudomonas, and all these things will come over there in core respiratory pathogens. In atypicals will be what all? Legionella, Chlamydia, Mycoplasma. These will all come in atypical pathogens. Right? Now we are in viral. We have thought that okay, Streptococcus pneumoniae के लिए ठीक है, मेरे पास sputum grams में आ गया. Virus थोड़ी तुम कल्चर कर सकते हो. तो वायरस के लिए तुमको सोचना पड़ेगा मैं क्या भेजूं. The thing I want to send is the nasopharyngeal PCR for influenza virus and respiratory syncytial virus, influenza virus. I've sent for influenza virus, isn't it? But in which patients I will do that? Okay, in which patients I will do that? In those patients that I have a strong suspicion that this may be a viral illness which is interstitial in nature. I did an ultrasound, I saw bilateral, there are interstitial pattern which he described as bilateral air bronchograms and X-ray showing bilateral infiltrates. Okay, patient having an immunocompromised state who basically diabetic for a long time and has a recent LRT at home, somebody at home has now given this to him. Something like that, if the patient comes, I will do a swab for nasopharyngeal swab for H1N1 influenza. Right? Clear on this? However, in the event that I am in the middle of an epidemic, in the middle of a situation where it is prevalent, for example, it's seasonal. It's in this season. It's in this rainy plus winter season that influenza goes out. I don't need to do this. I will just give oseltamivir. You understand? I don't have to do this. I will have to just give oseltamivir empirically. Clear? समझ में आ रहा है? समझ में आ रहा है मैं क्या बोल रहा हूँ? Clear on this till now? So my choice of antibiotic, choice of my test, you're understanding? Why am I sending a nasopharyngeal swab? You've understood this? So if it's an epidemic, but it's in the summer months, I don't think there's influenza in the summer months. There is no epidemic going on. I don't really need to start oseltamivir. But if I'm in the presence of my winter season, and I have these features that are coming inside, I would think, yeah, let me give it empirically, and I'll start oseltamivir empirically. Clear? Similarly, on the same breath, you can say that in the absence of H1N1, I still cannot remove my oseltamivir because I'm in the middle of an epidemic. I'm in the middle of my seasonal variation. Are you understanding? So if I started oseltamivir, I will not be taking it off, saying that okay, my nasopharyngeal swab is negative for H1N1. Can I stop the oseltamivir? No, it is not advisable. Clear? Clear till now? Clear? So now have you understood when I will send a multiplex PCR? So Vidya, when you will send a multiplex PCR?
So when there is strong suspicions of viral.
When there is no, I'm not talking multiplex PCR. Viral PCR is different. Multiplex PCR, bacterial PCR.
Bacterial, sir, in case of Streptococcus pneumonia.
No. When will I send?
We have suspicions that we need a higher antibiotic.
Yes, that is the answer. Vidya, don't sleep. So when we are having a situation where I'm thinking that I'm going to use other than the usual antibiotics, that is where I'll send multiplex PCR. Other than the usual antibiotics. Clear on this? When I'm going to use other than the usual antibiotics means I'm thinking of bacteria like Acinetobacter pseudomonas. Otherwise, Streptococcus pneumonia would be actually easily responsive to ceftriaxone. You are you understanding? That is where I probably use multiplex PCR. Where will I use multiplex PCR for PCR for virus?
So same interstitial pneumonia cases when we get lobar infiltrates.
And when I have a strong suspicion of having a viral pathology, I want to do a, or the patient is having comorbidities and patient is immunocompromised. There I will use this thing. Clear? Nasopharyngeal swab. Huh? Clear till now? So we've just gone to the microbiology saying we are doing blood culture, we are going to do sputum, Ramstein and culture, we are going to do a multiplex PCR in indicated cases, we are going to do multiplex, we are going to get H1N1 swab in indicated cases. Clear on this till now? Clear on this? An ultrasound gives us a very good picture. The ultrasound will actually give you the presence of maybe an effusion. You did see all these features that we had. We had air bronchograms, bilateral air bronchograms. But in the event that you have an effusion, then I will send a sample of the effusion for again Gram-Stein culture and routine and microscopy. If I have an effusion that I am seeing, I will put in a needle and I will send that as a part of my culture because at the end of the day, I need something in my hand. You know, I need something in my hand. That is why I am doing so many investigations to figure out what is the antibiotic that I need to give. Clear? Clear till now? Clear? Okay, now the question comes to the management. It comes to the management. Before we go even into the antibiotic, what are you going to do in these patients? Patient has come in, let me give you the patient. Now, so the patient has come in, RR is 20, 24. Okay, patient had fever, leukocytosis, blood WBC counts as 16,000. He's breathing at a rate of 23, 24. Saturation is 90, 91. So I'm going to put a saturation. Put a saturation of 88. I'm saying a RR of 16. I'm putting a pulse rate of 110, and that's why the patient is in the ICU because the pulse rate is high. Okay, and saturation is this. Okay, what are you going to do here? Okay, you have done a chest X-ray, it shows pneumonia. You have done this leukocytosis 14,000, and there is a temperature that is more than 39 degrees. What do you do in these cases? How do you manage this patient? What will you do? This patient is in front of you. This patient in front of you, want to know the blood pressure? Blood pressure is 100. 10 by 60. This is your patient. This patient is right in front of you. You have a blood pressure of 110 by 60. You have an RR that is around 16. You have a saturation of 88%. You have a pulse rate of 110. You have an X-ray that shows a patch. You have leukocytosis 14,000 and temperature of 39 degrees. What are you going to do?
Sir, I will first take proper history.
No, that's all done.
Yeah.
That's what are you going to do? We are in management. We have finished history. We have finished all these things. What are you going to do?
Sir, if that patient has already received antibiotic in last 3 months.
We are not in management. You're going to leave the patient like this?
Supportive
Huh?
supportive care.
What is that? Wait, hold on. What are you going to do?
I'll give first a supplement of oxygen if saturation 88, and then.
So the answer is, if you have a patient of pneumonia, my entire thinking in pneumonia is I want to prevent this patient from having endotracheal intubation. The thinking is like this. What is my thinking? I don't want this patient to go on a ventilator. This is my first thinking that will come to my mind. I don't want this patient to be mechanically ventilated because it comes with its own set of problems. Okay, so the answer to this is, if you have a patient that is of this nature, I would put this patient on something called as HFNC. Why? I would want to put the patient on HFNC because this patient has got a pneumonia. There will be surrounding areas that are collapsed. They need some amount of positive pressure that needs to be there. I need to titrate as FiO2. Right? So I will not use supplemental oxygen. I will use HFNC. That is your answer.
But sir, RR is
Yes. But what has been proven is that if you were to use HFNC and oxygen in patients of PF ratios that are less than 200, it actually prevents intubation compared to supplemental oxygen. What is our thinking? Prevent
Intubation.
You understand? So I want to prevent an intubation. So my answer here would be HFNC, and needless to say, it is going to prevent intubation because what will happen in this case? This patient's saturation is on the lower side. He has a patch. As time goes, RR is going to go from 16 to 26 to 28. This is going to occur, and when that occurs, there is going to be self-inflicted lung injury. Self-inflicted lung injury, atelectasis, patient going on a ventilator. Are you understanding? And we know from fluoride study that those patients whose PF ratios were less than 200, less than 200, in those patients of community acquired pneumonia who are admitted to the intensive care unit, oxygen versus HFNC actually supplemental oxygen versus HFNC was proven to be superior to prevent endotracheal intubation. That's why the answer would be HFNC, and that is why many times when I come into the ICU, I immediately tell HFNC to convert करो. बोलता हूँ कि नहीं बोलता हूँ? हाँ, oxygen पे लगा के रखा हुआ है. So if it's pneumonia, it's not. This is not the same thing with other cases. I'm talking of pneumonia. I'm talking pneumonia here. Clear? This is the first thing. Now you think, if there's HFNC, why not NIV? So which of the patients in which I use NIV? So oxygen is out. By now you have understood severe community acquired pneumonia, oxygen is out. Oxygen for the ward. Oxygen for the ward, or is the patient is getting better and getting out? Okay, so oxygen is supplemental oxygen is out. Okay, I want to give that small amount of positive pressure. I want to wash out that dead space, and that is why I am giving that HFNC. So if a patient is in this situation, I will give HFNC. What about NIV?
In respiratory distress, use of accessory muscle.
So if this patient has an RR that is fast, if the patient that has an RR that is fast, okay, if the patient is RR, what has been known is that NIV is superior to HFNC. What has been said is NIV is superior to HFNC if the RR is fast. Okay, that has been proven in community acquired pneumonia that if the RR is fast, I want to give NIV more than HFNC. So I'll put the patient on NIV. I can't put the patient on HFNC and wait and watch. There I'll be using NIV. Where I'll use CPAP. Right? So in NIV there are various interfaces. There is mask and there is helmet. Okay. From studies, what we know is that if the PF ratio is less than 150, the helmet is supposed to be superior as compared to the mask. The helmet is superior as compared to the mask. Clear? So if your PF ratios are less than 200, I'm going to give HFNC if the RR is okay. But if this patient has got RR that is elevated and he is in distress, so definitely you have to you going towards intubation. But to avoid the intubation, I can use an NIV. And if the PF ratios are alarmingly low, it's less than 150, I would use a helmet device. Clear? I'll use a helmet device. Clear on this? Clear? So this is how you would probably look at the interface as per observational data. Okay, as per data that comes in, as per data that's there in the market, you would probably look at in literature. This is what we do. This is what you would probably do. Mask, helmet, and HFNC. Ashok, clear?
Yes.
So is oxygen something you want to give now? No. HFNC is something you will probably give. And helmet is something that you want to do, or mask ventilation is something you want to do. This is ideal world, okay? This is ideal world. If ideal world, this is what I would probably do. Of course, we have to balance a lot of other things that come into the picture. So we take a lot of risks here and there, but this is ideal. My parent, I would do it like this. You understanding? This is what is ideal. Clear? Any doubts till now? Any doubts till now? Okay. So this is about this. What about the fluid now? What about the fluid? So in short, if there is hypoxia, HFNC, if the RR is okay. If hypoxia, RR not okay, NIV. In NIV, if the PF is much more lower, helmet. Simple. Now, what if the blood pressure is low? If the blood pressure is low, I would not really blast this patient with IV fluids. So conservative fluid strategy. Conservative fluid. If the BP is 100, I don't blast this patient by giving 2 liters of fluid and 3 liters of fluid. No. Conservative fluid strategy. It's very important to have conservative fluid strategy in pneumonia because it will all leak into the lung and cause this patient to go into ARDS. Okay, it will pneumonic ARDS. Clear? So it's conservative fluid strategy when it comes to management of these patients in the ICU. Okay, conservative fluid strategy. You can just give 500 ml and wait. Don't really push this too much. Don't really give too much of fluids. It's very essential that you don't do that. Okay, very essential because you give fluids, patient will go to ARDS. Clear? Now, next question is you have done all these investigations. The next thing that comes to your mind is what antibiotic to give. So, what is the antibiotic you give to this patient, Niharika?
First choice is
Ideal word.
azithromycin, Victor's, macrolide.
You are telling too many things together. You answer properly if you know. Okay. What is the antibiotic you will give?
Azithromycin.
What is azithromycin?
Typical cover.
You always should remember to know your physiology, pathology, pharmacology well. It's very important. Okay, you can't. So usually when you have community acquired pneumonia, you have to have your backbone as a beta-lactam antibiotic. It has to be a beta-lactam antibiotic backbone. the backbone has to be beta-lactam antibiotic. When I say beta-lactam antibiotic, Vidya clearly mentioned that it has to be third generation cephalosporin onwards. So when I say third generation cephalosporin onwards, you're looking at ceftriaxone onwards. Look at ceftriaxone onwards, ceftriaxone, cefepime. These are the things that you're going to look at. Okay, so looking at beta-lactam antibiotics, where you're going to look at anything more than the third generation cephalosporins. Clear? Or third generation cephalosporin or BL-BLI amoxiclav or BL-BLI amoxiclav. Beta-lactam is inhibitor, amoxiclav. In addition to macrolide. Question is, do I give this or do I just give a fluoroquinolone? Either you can give just a fluoroquinolone or a combination of beta-lactam fluoroquinolone or beta-lactam and macrolide. Right? What we know now, is there a head-to-head study? There is no head-to-head study. There is no head-to-head study that says give quinolone versus this. There is no head-to-head study, that's why it's plus or minus. There is no head-to-head study, right? But what we know is that we are a country where there is tuberculosis. So we would probably not want to use fluoroquinolone, number one. Number two, we know that fluoroquinolone has got more drug interactions as compared to macrolides. Second thing. Third thing, we know that the QTC prolongation is both there in macrolide as well as quinolones. Okay, so head to head, though there are observational data that says fluoroquinolone has got more adverse effects, that is why we go ahead and give a macrolide in combination with beta-lactam. That's why you don't see fluoroquinolones here. You understand? The question that comes is, am I going to use a macrolide plus a beta-lactam? Beta-lactam is inhibited higher than ceftriaxone. Am I going to use piperacillin tazobactam? Am I going to use cefepime tazobactam? That's the question we have to answer. Because even streptococcus pneumonia, severity does not determine that. It is not patient is very severe, so I'll give higher antibiotic. It is not like that. It is not that the patient is hypotensive, so I'll give meropenem. It is not like that. Streptococcus pneumonia can also be high severity pneumonia with hypotension and septic shock. And streptococcus pneumonia drug is ceftriaxone. Are you understanding the issue? The issue is you cannot couple by saying, "Arey, BP is 70 systolic, let me give meropenem." It doesn't work like that. It is not like that. Streptococcus pneumonia also will show low blood pressure and DIC also. Multisystem organ failure also. Are you understanding? So for that the treatment of choice is ceftriaxone. The treatment of choice is ceftriaxone. There is nothing else in that. Are you understanding? So the question that comes to me is when will I use it, and that is the reason you need to know which are those patients which will have the higher chances of having drug-resistant pathogens, Pseudomonas and Acinetobacter. And that's why we look at all those criteria that you mentioned, saying that has he received an antibiotic in the last 90 days? Was he colonized with the Pseudomonas? Was he colonized with an MRSA? Does he have comorbidities? Is this a presence of immunocompromised state? Putting all of these together, I can think, okay, this patient may harbor a Pseudomonas or an Acinetobacter. Hence, I want to give some Pseudomonas, some antibiotic that is actually sensitive towards Pseudomonas and Acinetobacter. You're understanding? So the choice of whether I want to give ceftriaxone or cefepime or any of those BL-BLIs or meropenem will actually determine not on severity. It will be based on what is the possibility of him having this, because this is coming from the community. So what is his situation? Where is he? Is he coming from a nursing home? Is he a dialysis patient? That is what all that you had mentioned. Okay. So if he's coming from that area, I would probably want to give a higher antibiotic. When I say higher antibiotic, I am broadening the spectrum to cover Pseudomonas and Acinetobacter. When I say higher antibiotic doesn't mean just the higher class. It means you're broadening the spectrum. You understand? Clear on this? So we've reached up to here. We've understood the antibiotics as of now. The question that comes is, what do I do with the steroids? So do I give steroids and what do I do?
It is not routinely.
So here, before I forget, this NIV is there, NIV. Any patient who's got COPD and another indication for NIV will actually get NIV irrespective of what this is. In a patient who is COPD or any other indication, sleep apnea, something like that is there, he's on NIV, this patient will have to be put on NIV. Clear? Clear on that? That is clear, huh? NIV. Okay. So, where were we now? Steroids. So, what is this about steroids, and what is this controversy about steroids?
Usually we can use steroids in case of sepsis with septic shock.
No, but what is the controversy? Why steroid is coming in the picture in the first place?
So because of that inflammatory response is there now.
Why is that coming? Then you give for everything, no? Give for any infection. If that is the case, everything in your body is an infection when they come in. Every patient should get a steroid, if that is the case. Are you understanding? Everything in your body, pancreatitis is inflammation, you give steroid. Everything in your body is an inflammation, right? Why in this they are talking about steroid? Why is the controversy here? The controversy is something like this. So when you have you seen Jarisch-Heisenberg reaction? You know what is Jarisch-Heisenberg reaction? It's a very interesting reaction. Syphilis patients. In syphilis patients, you give penicillin, no? They develop ARDS. Why did that occur? Because it releases a toxin, and that toxin causes ARDS. Similarly, the commonest bug here is Strep pneumonia. Strep pneumonia has got a toxin in it called as pneumolysin. Okay, what happens to this pneumolysin? The moment Streptococcus breaks, it exudes out that pneumolysin, it may cause something like a Jarisch-Heisenberg reaction. So the theoretical concern is, okay, there is going to be an inflammation that is coming from that toxin, the treatment of which is steroid. So let me give steroid. That is where the entire theoretical concern is all about. But what we know now is that it doesn't work like that. It is not something I want to do, and that is why I will follow the Surviving Sepsis Campaign guidelines, that in the event of a shock, in the event that the patient is having a shock or another reason that the patient is on steroids, for example, he's on long-term steroids because of asthma. Okay, something like that. Or COPD, he's on long-term steroids because of asthma, COPD, or he's on long-term steroids because he's on transplant patient, he's on steroids for that. In those patients, I will give steroids. So there are 3 indications where I will probably give steroids. When the patient is having septic shock, patient is asthmatic, or another indication for having those steroids. Right? What is the steroid I'd like to give here? Question is, what is the steroid? So I can either use the Surviving Sepsis Campaign guidelines and give 200 milligrams of hydrocortisone, or I can give methylprednisolone at 0.5 milligram per kilogram twice a day. I want to give 0.5 milligram per kilogram. Don't consider this and equate this to ARDS. ARDS is different. This is pneumonia. ARDS has got a different reason to give steroid and a different technique to give steroid, a different controversy over steroid. Okay, we are talking about pneumonia, we are talking about an infective cause. And an infective cause, while you give a steroid, is what you are thinking as. Okay, so in that case, I want to give 0.5 milligram per kilogram of methylprednisolone twice a day. Clear? Huh?
0.5 mg per kg full day or
Twice a day.
BD means
BD.
1 mg per kg whole day.
हो जाएगा पूरा. So on an average 40 milligram twice a day.
So 200 milligram hydrocort statin. And then
No, 50 again 4 times a day or 3 times a day, something like that. Huh? Clear? So this is what is recommended. Okay. So you may want to give 200 milligrams of hydrocortisone, like how Surviving Sepsis Campaign guideline tells you. You can do that also. Infusion of 200 milligrams of hydrocortisone. That's what the Surviving Sepsis Campaign guidelines tell us. You can do that also. But what does the estimate tell? The European Society, which actually looks at, as I started by saying, there are 2 guidelines that look at IDS and estimate. The estimate says give 0.5 milligram per kilogram of methylprednisolone twice a day. That's what they say. But they also say in the same line that you may want to use the Surviving Sepsis Campaign guidelines dose also of hydrocortisone, equivalence of hydrocortisone. Clear? Huh? Clear? So we've talked about how you come into the diagnosis of community-acquired pneumonia. We have come to how does a patient present to you. We have understood the disposition of the patient, whether the patient goes to the hospital or home. We have understood in the hospital how it goes to the intensive care unit. We've understood if it comes to an intensive care unit, what are the investigations that I need to send and why I'm sending those investigations. And we've come to what the treatment and management is all about. Clear? So any questions on this? We've completed community-acquired pneumonia, severe community-acquired pneumonia. Any questions on this? Any questions on this? Huh? Arshad? Any questions on this?